Good morning, everyone. Myself, Dr. Harshil. We will be starting with the case presentation of today. So, the case is a 44-year-old male. He's a resident of Pratapgarh, Uttar Pradesh, working as an industrial worker. Presented with chief complaint of yellowish discoloration of sclera and urine for 1 month and pruritus for 1 month. On elaborating history of present illness, patient presented with yellowish discoloration of sclera and urine for past 1 month, which was insidious in onset, gradually progressive, which was not associated with any pain abdomen. There are no prodromal symptoms like myalgia or malaise, and it was associated with pale colored stool. Patient was also having pruritus for 1 month, which was gradually progressive, started in hands and progressed to other parts of body. And it is more at night time, and it also disturbs his sleep. It is also associated with loss of appetite, and loss of weight is also present. However, it is unquantified. Patient is saying there is loosening of clothes present over the time of illness. Coming to negative history, there is no history of fever with chills. There is no history of nausea or vomiting. No history of abdominal distension. There is no history of melena or hematemesis. No history of shortness of breath, chest pain or cough, and there is no history of back pain. In treatment history, also the patient underwent radiological investigations after admission, and following which he underwent insertion of 3 tubes, one on the left side of upper abdomen and 2 on right side, most probably PTBD, and currently it is draining 150 ml per day on the left side, and right side 100 to 150 ml per day in each tubes. And the yellowish discoloration pruritus has decreased after this intervention. There is no significant past medical or surgical history. In personal history, patient consumed mixed diet. There is no addiction. His sleep is disturbed due to pruritus. However, it has decreased. The bowel habits are regular, once per day, pale colored, and there is no significant family history suggesting of any cancer-related diseases. Now, summarizing my disease, a 44-year-old male without any medical comorbidities and addiction, having painless progressive jaundice for 1 month, associated with generalized pruritus, pale colored stool, loss of appetite and unquantified weight loss, and relief of these symptoms after PTBD insertion for biliary drainage. Go back.
Go back even further. Yeah, when you said industrial worker, you need to specify whether he has worked with dye industry or dyeing industry, because that has a clinical significance for cholangiocarcinoma and carcinoma gallbladder.
Okay, sir. So he has worked in an electric with welding and the other stuff. No history of dye exposure.
Yeah, what Dr. Desai is pointing out, that industrial exposure, specific industries, specific exposure. So I think dye, rubber also is important. Instead of just saying industrial, you have to go with more details. Some environment.
Sir, your voice is not clear.
What I was saying, that the point which you made is important, that instead of just saying industrial worker, the student has to ask which industry, what exposure, and how long he has been working there. Because it is not that if he has been working there, say, for a couple of months or a couple of years, that is important. But if he has been working all through in an industry where he is exposed to these carcinogenic chemicals. So I think dye, you said, probably rubber industry also. And I'm sure there must be some others. So more detailed exposure history is important. So with this presenting complaint, as soon as you have this patient with jaundice and pruritus for 1 month, maybe we can go to the next. So it's a, okay, next. Yes, next. Fine. So I think we can go to the summary. Yes. So anything important which you have missed in the summary? Or maybe I'll discuss that later. So based on this summary, what do you think? Exclude the last line, exclude the PTBD. Suppose the history of PTBD was not there. Suppose he had not received this.
That is the first differential because it is a painless progressive jaundice with weight loss. And in that, sir, first differential will be CA, carcinoma of gallbladder.
Could it be benign?
Yes, it could be, but the other negative disputes are not suggestive of cases there should be pain. Chronic pancreatitis, but there is no such.
Sound is not clear, sir.
In stone disease, sir, there is no history of any pain suggestive of CBD stones. And in case if we are thinking of chronic pancreatitis with any stricture formation, but there is no any chronic history suggestive of the similar.
These are the only two causes of benign jaundice.
Other than that,
But let
sir,
me go back. Why do you say that this is surgical jaundice? Why not medical jaundice?
sir, painless progressive with pale colored stools and generalized pruritus. In cholestatic,
So jaundice, pale colored stool and pruritus can all be there in hepatitis. Whenever you have a short history of jaundice, you cannot exclude hepatitis. Although, yes, you are right, hepatitis would usually have pain, and that pain is different from the pain of biliary colic. That is a dull, diffuse, mild to moderate ache because of stretching of the capsule because of hepatomegaly caused by inflammatory swelling. So that is one point. Any other point against the diagnosis of hepatitis? No prodromal symptoms. What are the prodromal symptoms of hepatitis?
so malaise, myalgia,
And anything specific in smokers? They develop aversion to smoking. Even those who have been chronic smokers, heavy smokers, chain smokers, they sometimes say that during these days, I don't feel like smoking. So that has been reported in some texts. But whenever you have a short history, painless, progressive jaundice, pruritus, pale colored stool, high colored urine, all these can be there because in hepatitis, there is a phase of intrahepatic cholestasis where all features of obstructive jaundice can be there.
Another thing you have to take history is the history of exposure to heavy metals. Arsenic, mercury, lead have been known to be associated with gallstones with gallbladder cancer. So that's another important history you need to take, whether he has been exposed to this either in the industry or based on his locality, whether there is any such association. Whether he lives along the banks of the Ganges also is important, because if he is along the distributary of the Ganges, he is more likely to develop gallbladder cancer. Another benign disease which you should be thinking of in relation to arsenic is sclerosing cholangitis. Arsenic causes secondary sclerosing cholangitis. So that's another reason you should be taking that history.
yes.
And in hepatitis, you can have severe anorexia. Okay, so and if the patient has severe anorexia and he has jaundice for about a month, he's bound to lose some weight. So loss of appetite and weight loss over a period of 1 month where you have jaundice, I don't think you can rule out hepatitis in this case. I'm discussing this when there is no history of PTBD. Because the moment you say there is history of PTBD, then the whole story changes. So if we say consider only the first paragraph of summary, it would be difficult to rule out hepatitis. Now we come to surgical jaundice. So I asked you, what can it be benign? And so first, it is better to say that the common causes of benign surgical obstructive jaundice are, number one, CVD stone. CVD stone is the commonest cause of surgical obstructive jaundice, both benign and malignant. And obviously, benign, it is the commonest cause. But if there is no history of pain, then you should not make a clinical diagnosis of stone disease, although it can be there, but it is unlikely. You should not say that I would like to consider. The other causes of benign, you said chronic pancreatitis. Is there something more common than chronic pancreatitis? Benign? I don't know whether it is more common or not, but choledochal cyst, isn't it?
Yes.
So choledochal cyst, again, just jaundice without pain is possible. Without cholangitis, it is possible. So similarly, chronic pancreatitis causing biliary obstruction alone and presenting with biliary obstruction only without history of pancreatic pain is unusual, unlikely. I don't think you can or you should make a clinical diagnosis. PSC, Dr. Desai said, so you could have answered saying that since there is no history of cholangitis, I would not like to consider that clinical possibility, although uh, everything is possible. You have unusual manifestations of all diseases, but when you make a clinical diagnosis, you make it based on the classical presentation. Now, obviously, he has this history of PTBD. What does that indicate?
So that indicates that there is some blockage in the drainage that requires the insertion of a catheter to decrease the bilirubin and to for the relief of symptoms.
So first indicates that this is obstructive, surgical obstructive jaundice, because nobody would do a PTBD in a medical jaundice because of hepatitis. That is number one. Any other thing PTBD indicates?
The pruritus was disturbing his sleep.
Okay, so you were thinking of malignant surgical obstructive jaundice. Let me question you on that, then we'll come back to PTBD. What do you think is the malignancy here?
Or cholangiocarcinomas.
In this case, based on this history,
based on multiple PTBDs, what possibilities are there? What has happened in the reason? What is the reason behind putting multiple PTBDs?
or
separation of the ductal systems.
so out of these two, why not periampullary or pancreatic?
Sir, periampullary and pancreatic and endoscopic drainage would have been
So
done.
PTBD indicates that based on whatever other investigations they did, they probably found a high obstruction, hilar obstruction. Because if there was evidence of low obstruction, nobody will go directly for PTBD. You will at least attempt an endoscopy. If endoscopy fails, then yes, you will do a PTBD. So the fact that PTBD is done as the first intervention for biliary drainage itself indicates that it was a high block. Now, high block, the two common causes you rightly said are gallbladder cancer and cholangiocarcinoma. So which one is more likely in this case?
So his resident of North India, AGB first.
See, it's the residence or age or religion or caste or diet. All these are risk factors, which means that as a group, if you belong to that group, you are more likely. But that should not be the point to make a diagnosis that just because somebody lives in North India, I don't think you should give that reason. The point here is painless progressive jaundice. Painless progressive jaundice, what is more likely, cholangiocarcinoma or gallbladder cancer? Cholangiocarcinoma. Majority of patients with cholangiocarcinoma will have painless progressive jaundice, whereas more patients with gallbladder cancer and jaundice will have pain. Although we know that a small tumor at the neck or cystic duct, which is causing direct involvement of the CBD, may present with painless progressive jaundice. But if it is painless progressive jaundice, multiple PTBD is required, it is more likely to be hilar cholangiocarcinoma. You cannot say that it is hilar cholangiocarcinoma. The possibility of GBC neck, which is infiltrating So if it is GVC neck, then it will infiltrate the CBD. Why would it cause multiple ductal obstruction? It should cause mid CBD obstruction, single site of obstruction.
But sir, if it is the hilum, then
Not hilum. If it infiltrates the liver, so a GBC neck, if there is infiltration into the liver, you know that the right portal pedicle is lying just there, few millimeter depth, and the right anterior and posterior pedicles may be involved. So that is how. If it is GBC neck involving only the CBD and no liver infiltration, then you would get a picture like a mid CBD obstruction. What are the causes of mid CBD obstruction? Mhm. Mhm.
then CBD is CBD that can also give the picture.
Any benign cause of mid CBD obstruction?
So stricture is told to get replacement.
Colloquial says there's no mechanical obstruction. It's a functional stasis. Mirizzi syndrome. Mirizzi syndrome is the classical cause of mid CBD obstruction. The typical presentation is patient has jaundice, may or may not have cholangitis. You do an ultrasound, you find a large stone sitting at the neck of the gallbladder. There is IHBRD. You can see the confluence forming. You can see the common hepatic duct, but below that, you don't see the duct. That is the classical picture of Mirizzi. And sometimes it may be very difficult to differentiate it from a GBC or a mid CBD cholangiocarcinoma. But for that, you will not require multiple PTBDs. A single PTBD would be enough. Multiple PTBDs indicates that definitely the hilum is blocked, and because 3 PTBDs were required, that means the sectoral separation. So in this case, with this history, would you have done 3 PTBDs? I say it is hilar cholangiocarcinoma. He comes to you. Would you have done 3 PTBDs? No. It is hilar cholangiocarcinoma and separation.
Can't hear him, sir.
What is the intent of our further clinical workup if we are planning any resection, or if there is any requirement of bilirubin is very high and we are anticipating any major liver
You would have
dysfunction?
done 3 PTBDs. Suppose he is for resection. Would you have done 3 PTBDs?
No, sir.
Sir is trying to ask, in the absence of cholangitis, would you drain all systems?
See, the only indication of multiple drain is cholangitis. For everything else, you first drain one part. Now here, if there is sectoral separation, best is to drain the left lobe first. See what happens. If the indication is pruritus, even that alone can relieve pruritus. If the indication is to bring the bilirubin down, we know that only one side drainage can bring the bilirubin down to whatever level you want. If it doesn't, then you do the indication of, although you did not mention whether all 3 were done in the same sitting, but the only indication for draining all systems in the same sitting would be uncontrolled cholangitis, which he did not have. So that is why we question whether you would have done all 3 PTBDs and whether you would have done in one go or one by one. Okay.
Yeah, what are the factors you consider in doing a PTBD in a patient with cholangiocarcinoma? What all factors play an importance in draining the systems?
So the factors first related to the patient, and other is related to the disease. In case of hilar cholangiocarcinoma, first the disease, if there is, we are planning for, so first is intractable cholangitis, as sir said, that is not controlled with antibiotics, we have to drain. Other symptom relief is intractable pruritus. Then altered renal functions. Before any surgical intervention, if RFT is altered, we have to drain and wait for the settlement of RFT.
Is liver
Other
atrophy possible in cholangiocarcinomas in one portion of the liver as opposed to the other portion of the liver?
What, sir?
Is atrophy possible in one lobe? Would you drain a lobe that is atrophied in the absence of cholangitis?
Sir, if there is atrophy of liver, that indicates portal vein involvement, vascular involvement, most probably. So I would like to the other normal lobe that we are planning to preserve.
Yeah, so that is an important thing. You have to consider, is there cholangitis or not? Is there severe pruritus or not? What is the future remnant liver that is going to be there? And whether there is any evidence of atrophy hypertrophy complex, which will decide where you're going to put your PTBD. These are the factors that need to be considered whenever you are putting PTBD in a case of cholangiocarcinoma. The
Yes.
other factor is how long are you going to keep it? That also needs to be decided. Based on that only you will be putting the tubes, the relevant tube.
Yes.
And it's a Japanese philosophy to do PTBD drainage. Nimura is the one who first advocated mandatory PTBD in all segments of the liver so as to ensure a mitochondrial recovery in obstructive jaundice, which prevents future remnant liver failure.
So,
Yes, sir.
Jasveer has posted a question: what symptomatic indication in such patient to not to go for PTBD? So we've already mentioned that what are the indications for PTBD? Indications for PTBD are that if you consider the lesion to be resectable, if it is hilar cholangiocarcinoma, which means that you are planning a major liver resection. So according to the Japanese philosophy, any major resection, that means more than 2 segments of liver, they say that the bilirubin should be brought down to normal, preferably less than 3. So all Japanese surgeons and those who follow Japanese philosophy would do that. Some centers in the West do not follow this and they go ahead with major liver resection even in presence of jaundice. But obviously their results are much poorer in terms of mortality and morbidity as compared to Japanese. So I think more and more groups are following the Japanese philosophy. The only exception is if it is a left resection, then there is a school of thought which is emerging that left resection can be done without bringing the bilirubin down. So one indication is if you are planning a major liver resection. Second is if you have cholangitis, which is not responding to parenteral broad spectrum antibiotic treatment within say 24 to 48 hours. Or if it is so severe that the patient presents with systemic sepsis and you don't want to wait even for that time. So uncontrolled or uncontrollable cholangitis becomes the other indication. And this is one situation where in the first go, you may like to drain all systems because you don't know which system is infected and most likely all systems are going to be infected. The third indication would be if the patient has intractable pruritus, which is affecting the quality of life, and you know that definitive treatment is going to take time. So, as a temporary palliation of that distressing cholangitis, sometimes you may have to do a PTBD, which may relieve the pruritus to some extent. If these indications are not there, then then you don't do a PTBD. Or if it is unresectable, then as a definitive treatment, palliative treatment, first you do PTBD, external drainage, then the interventional radiologist will internalize these. If cost is a constraint, then it becomes an external internal. So you pass the catheters across the tumor into the distal bile duct or into the duodenum and then cap it, but then the patient remains with tubes hanging out. And if you can afford, then you place or replace all these PTBDs with self-expandable metal stents as the definitive palliative treatment. The advantage of an external PTBD is that both in hilar cholangiocarcinoma and in gallbladder cancer, through these PTBD tubes, the radiotherapist can introduce radioactive wires, and you can give intraluminal brachytherapy, which in some reports it has been shown that it increases the duration of patency of the stents which you are going to place by controlling the tumor to some extent. And I'm not sure whether there is evidence, but maybe it can prolong the survival to some extent. So if you want to give intraluminal brachytherapy, you have to keep the PTBD tube for some time. And then after giving intraluminal brachytherapy, you replace it with a stent.
Also, it's important to note that when you're doing a resection of multiple bile ducts and you're going into secondary bile ducts, a PTBD catheter helps in localization of the bile duct and helps in identifying the bile duct. So you should always drain it up to the level of the tumor so that you know which is the highest extent of the tumor based on your imaging.
Coming to general examination, patient is conscious and oriented, moderately built and nourished with ECOG of 0 and BMI of 19.4. He is vitally stable. There is icterus present and scratch mark present over both the upper and lower limbs. There is no pedal edema. There is no left supraclavicular lymphadenopathy, and Bekenstein examination was normal. Coming to abdominal examination, on inspection, abdomen is flat, umbilicus is central and inverted. All quadrant moved equally during respiration. There is no visible mass or scar sinuses, no peristalsis or pulsation. There are 3 tubes, as we mentioned, 2 in right hypochondrium and 1 in epigastrium. Scarch marks of itching present over the lower abdomen, and other hernia verifies and external genitalia were normal. On
Since you mentioned the tubes at this stage, it is always good to mention what they are draining and whether there is any peritubular leak.
Okay. Coming to palpation, abdomen is soft. There is no local raise of temperature, non-tender. There is no palpable lump or no hepatosplenomegaly. On percussion, liver dullness starts as 5th intercostal space with liver span of 14 centimeter in mid-clavicular line. There is no shifting dullness. And on auscultation, normal bowel sounds were heard. Digital rectal examination revealed pale color stool. There is no any mass or nodule found. And this was the image of the patient side. Other systemic examination of respiratory and cardiovascular system were within normal limit. Now to summarize, he is a 44-year-old male with no comorbidity or addiction, having painless progressive jaundice for 1 month, associated with generalized pruritus, pale colored stool, loss of appetite and unquantified weight loss, and relief of these symptoms after a PTBD insertion. He is icteric with scratch mark over abdomen and extremities without any palpable mass or organomegaly, and having pale color stools on digital rectal examination. And as we mentioned, there are 3 PTBDs draining bilious output.
Based on this history, can you say whether these are just external PTBDs or whether they have been passed across the tube?
Sir, most probably they have not passed across because all of them are draining bilious output, and there is no enteric or pancreatic content seen. It is bilious only.
So if it is pure bile, probably it is proximal. If it is looks like duodenal content, then. But suppose I say have they been passed beyond the tumor but still in the CBD, then they will continue to drain bile. So is there any other point in the history or examination which tells me whether it is proximal or across the tumor? What will happen if it is across the tumor? What change will happen? Color of stool. If it is across the tumor, then the stools will become normal colored. So if I don't know whether you mentioned when was the PTBD done, but if it was done a few days ago and it is across the tumor, then the stool will be normal colored, but stool is still pale colored. So most probably it is still proximal. Okay. So this patient comes to you before the PTBD was done. What would you do? In this case, sonography is an extension of general examination. It is the investigation. Patient with jaundice, sonography is the investigation. In fact, in a large number of cases, a good ultrasound can give you the diagnosis. What did the ultrasound show? We don't have? Okay. What do you expect? Suppose this patient had an ultrasound, what did you expect to see?
So there will be
Hilar cholangiocarcinoma usually has a mass which can be seen on ultrasound. Mass forming is a type of cholangiocarcinoma, but not a common type. Common is the what is it called? Scira. Where there is just thickening, which would be difficult to appreciate on ultrasound, although good sonologists can. But usually there is no mass. In fact, the point to differentiate between a hilar cholangiocarcinoma or a mid CBD cholangiocarcinoma versus a GBC neck is presence of mass. If you see a mass, it is more likely to be a GBC rather than a cholangiocarcinoma. Dr. Nabeen Podial from Nepal says, could you comment on the color of the bile that arises at different levels along the biliary tree? I have noticed the color to be different in PTBD tube and T tube. I don't know whether I don't know whether the level would make a difference, or is it that normal bile would be in a well hydrated patient should be thin, watery, golden yellow bile. On the other hand, if there is stasis, it may become little turbid, it may become little it may become greenish yellow mucus, which is called white bile. Vinay, anything you know?
no changes.
I don't know whether there will be any difference in the. Only thing is that gallbladder bile and hepatic bile, they are different, because gallbladder bile, as I always say, in relation to cholecystectomy, is more viscid because it is mixed with mucus. It is thick. It doesn't flow very easily. It sticks to tissue and it is more greenish yellow. Whereas hepatic or CBD bile is usually bright golden yellow. Yes.
But a PTBD bile is the normal, so that might be
Yeah. Okay. So yes, IHBRD and on ultrasound. In this case, what would you have seen?
There is no mass formation. If we can involve the duplex Doppler scan, we can see the condition of portal.
Or Doppler, anything else? Just IHBRD? IHBRD तो periampullary में भी होगा, pancreatic head में भी होगा.
That will be collapsed.
The IHBRD with absence of formation of confluence, absence of joining of right and left, right anterior and posterior sectoral ducts. That is what a good ultrasound would have shown in this patient, because 3 PTBDs were required. Now we are going back. That is what was expected.
Now what will you ask him to see? 1, 2, 3, 4, 5, 6, 7. So I would like to ask him to see about the intrahepatic PUD radicals, common hepatic and common.
अभी इसका जो ओरिजिनल है वो किसके पास है? डेबिट कार्ड भाविका का है वो? हाँ, वो
You should always mention confluence whenever you are dealing with high biliary obstruction or mid biliary obstruction, you have to use the word biliary ductal confluence. So IHBRD, formation of confluence, then the level of obstruction. What else on ultrasound? Okay. इतना सोचना क्या है? Malignancy है. What else? Liver as well, cholangiolytic abscess, lymph nodes, ascites, isn't it? So ultrasound can give you the diagnosis in obstructive jaundice in a large majority of cases. If you see gallstones, dilated CBD stone, you know you are dealing with stone disease. If you see dilated extrahepatic bile duct, but no IHBRD, you know you are dealing with choledochal cyst. If you see multiple areas of dilatation and stricture, both intrahepatic and extrahepatic, probably you are dealing with primary sclerosing cholangitis. If you see IHBRD, the two drugs on the right side are not joining, primary confluence is not formed, you are dealing with hilar cholangiocarcinoma. If you see IHBRD, confluence is formed, proximal common hepatic duct is seen, but beyond that, you don't see any duct, gallbladder is collapsed, you are dealing with a mid CBD cholangiocarcinoma, or you are dealing with a gallbladder neck cancer. If you see IHBRD, entire biliary system dilated till the lower end, gallbladder also is distended, PD is also dilated, both the dilated ducts are coming very close to each other, there is no mass in the head of the pancreas, you are dealing with the periampullary carcinoma. If you see both CBD and PD dilated, but they are separated from each other, and there is a mass in the head of the pancreas, you are dealing with carcinoma head of pancreas. This is the classical double duct sign which was described originally, that the two ducts are dilated, but they are far away from each other. They are not coming close to each other. So a good ultrasound can virtually give you the diagnosis in a large number of patients with obstructive jaundice. And before that, if you don't see any IHBRD after 2-3 days of jaundice, you are dealing with medical jaundice. Ajay, you want to say?
I don't remember recently one of the classes.
Sir, आवाज नहीं आती है.
He was supposed to comment on MRI and CT scan, and he said that till date, even today, I take my sonography and I believe in my sonography more than before I get a CT scan, or even after getting a CT scan done to see some intrinsic details. So USG is still a more dependable thing, because one thing, it is observed dependent. He is good, he can see the details. It is something like, I say, a diagnostic laparoscopy is to be done by a first year, a second year, a final year, a lecturer, associate, and assistant, and then professor. So maybe Dr. Kapoor उसी के अंदर देख के कहेंगे कि I think I have seen more malignancies in the falciform ligament of the left side. So just see over there, and you find a metastasis over. This happened with us when we were at DCPG. Dr. Rajan told, I have to see it over there. Just show me over there was single metastasis, and we took that biopsy. That was made. So a professor coming and invading in the same thing. Everybody has done the same laparoscopy till date. We have done laparoscopy procedures, but same thing. The observer depends. It depends upon experience. Sonography is a very helpful investigation if you do it very correctly. If you find a bilateral biliary dilatation, confluence not getting formed, then you have to look at the second order. Then raise up to what the extent of the stricture is, which you want to see at MRCP now, not on CT scan. Then CT scan does not remain the investigation of choice, because now you want to see whether there is a stricture at the higher up on that, which you can see on sonography anyway. So it is a good investigation, what Dr. Kapoor has said.
And you must remember that ultrasound is a dynamic investigation, whereas CT and MRI are static investigations. You just put the patient in the machine and get film or video. Whereas on ultrasound, you can change the position, the direction of the probe. You can increase or decrease the depth and see what you want to see. So ultrasound is a very, very useful investigation, of course, in experienced hands. Okay, so this patient did not have an ultrasound. What else you would have done? We have the reports, pre-PTBD. Yes, this is pre.
Both are the same.
What do they show?
So before PTBD, there is no answer. There is no raised TLC, and coming to LFT, bilirubin is raised direct of total of 16 with direct of 13.6. Enzymes AST and ALT are normal 67 450. Alkaline phosphatase is raised 360. And INR of 1.4.
We have read the numbers. What is your interpretation?
Sir, there is obstructive jaundice with raised bilirubin of 16 without any evidence of cholangitis.
So deep or high obstructive jaundice with no cholangitis, so no evidence of cholangitis. And you could also mention that preserved nutritional status, his serum albumin is 3.5. He has lost weight, but serum albumin is okay, isn't it?
Yes.
Next, what would you have done? So suppose we had done an ultrasound, it showed IHBRD and confluence not forming, no mass.
So then I would have asked for a mass.
Why not CT?
To look for the level of confluence and biliary involvement, ductal involvement. MRIs.
What do you mean by level of confluence? Level of confluence would remain the same. It is the status.
Status of confluence and secondary.
So by and large, for high biliary obstruction, MRI and MRCP is the preferred investigation because you are interested to know what is the proximal extent of the block. That would decide whether it is resectable, whether it requires liver resection, or whether it can be only CVD excision. On the other hand, by and large, for a lower end block, as shown on ultrasound, most people would prefer a CT scan because then your interest is not the level of biliary obstruction, that you know. Then your interest is vascular evaluation, especially in CA head pancreas. So for hilar cholangiocarcinoma, for GBC with SOJ, most people would prefer MRI with MRCP and, of course, as you rightly said, MR angiography as the first investigation or as the only investigation, whereas most people for periampullary or carcinoma head of pancreas would prefer to do a triple phase or a pancreatic protocol CT scan. So what do we have here? Yes.
So this is the non-contrast film. Section of the CT scan, which is showing prominent biliovascular margin.
In a patient with obstructive jaundice, not this case, in a patient with obstructive jaundice, surgical obstructive jaundice, why do you want a plain phase of the CT? Why unnecessarily waste the film? Anything you want to see on plain? Where?
Or in case of CP with distal block, we can see for pancreatic calcification.
So most important, out of all the things, hepatolithiasis, how many will be radiopaque? Very few. Gallstones, how many will be radiopaque? Very few. But chronic pancreatitis calcification. So first is calcification to suggest chronic pancreatitis. Then you can say radiopaque stones in the biliary tree, and then you can say radiopaque stones in the intrahepatic. Okay.
So there is no evidence of any calcification or radiopaque stones. Now coming to the arterial phase and the.
Why do you want an arterial phase?
The vascular hepatic artery and other anatomy for if to see for the susceptibility of the disease.
So you want to look at the status of which artery in a high level.
Can you comment about the left lobe? How is it looking? Is there any crowding of the bile ducts?
HBRD, so suggesting atrophy of left lobe. Sir, coming to the question before, sir, right and left hepatic artery proper involvement of.
Which is the most important?
Hepatic artery proper. So,
in this case, hilar cholangiocarcinoma, right anterior and posterior sectoral ducts are most probably separated, requiring by double PTBT on the right side, which is the most important artery which you want to see. Left hepatic, isn't it? Because if the left hepatic artery is involved, in all like, or it is unresectable, because on the right side the ducts are involved predominantly, on the left side artery. Next.
This is the most important artery.
Sir, just a comment. Nowadays, people are preferring to resect in cholangiocarcinoma vascular structures. So, vascular involvement, only long segment vascular involvement is a relative contraindication for resection. So, I would say that atrophy hypertrophy complex is a major judge. You obviously can't make that the future liver remnant, that has to go. So in this case, from the imaging, the least we can say is it has to be a left hepatectomy with reconstruction of the right ducts.
Yeah, but on the right side, most probably there is sectoral separation. We will have to see what is the status there.
Yeah.
So what Dr. Desai is saying, what Dr. Desai is saying, that even if the proper hepatic artery is involved, or even if the left artery is involved, if it is resectable, reconstructable, for cholangiocarcinoma, there are groups which are aggressive in approach, and venous resection, of course, is a routine, but even arterial resection, they believe in doing, which is again or opposite of philosophy of management of gallbladder cancer, where most groups now, including Nagoya in Japan, have stopped doing vascular resections for gallbladder cancer. And this is because of the difference in the aggressiveness, the biology of the tumor. While cholangiocarcinoma is a low aggressiveness and favorable biology tumor, gallbladder cancer is an aggressive and poor outcome cancer. So the previous dictum which I was mentioning, that if the ducts are involved on one side and the artery or vessels are involved on the other side, it makes it unresectable. If you have an aggressive approach, if you believe and if you can do a vascular resection, that alone does not remain an indication for unresectability.
That's what I want to ask exactly that. Suppose you have a halocarcinoma, which is the artery that will notice that it is safe or not. It is usually the left artery that should be safe, because reconstruction of right artery is less safer, less common, because it is having a short. In the right system, that is having a shorter leg. So we do a right. And in right, if the vascular reconstruction is less common.
Who was the arteries?
So this is the right artery is just.
You show the arteries from above downwards, or you always show them from proximal to distal. So start from the celiac axis and go back.
Yes, sir. So this is the celiac axis. Now, upward, this is the common hepatic artery. Hepatic artery proper and right. Pointer. Yes, sir. The artery is the right hepatic artery at the periphery of the tumor, and this is most probably the segment 4 artery. And
Is the right hepatic artery involved?
not involved.
It is close to the tumor, but it seems to be patent.
Segment 4 artery looks involved inside the tumor, and this is the left hepatic artery, which is away from the tumor.
So the proper hepatic artery is free, right hepatic artery is closed but free, left beyond the origin of segment 4 is all right, but segment 4 branch of the left hepatic artery is going into the tumor. Okay.
Yes.
Show the tumor now. Show the tumor. So you were right that unlike the typical picture of hilar cholangiocarcinoma, here there is a mass at the heart, and a reasonably large mass for a hilar cholangiocarcinoma. What is the extent? Here you can see the ducts, you can see the dilated ducts. So you can show us even on this, it is almost like a CT cholangiogram.
Yes, sir. So there is left ventricular separation. You can see there is inferior and posterior separation.
What do you mean by left duct separation? You mean left and right?
You're actually able to see the confluence of the posterolateral duct and the anteromedial duct, from what I can make out from here. That's where it ends. So you got about 1 centimeter length, which you can free from the tumor. So the only issue will be the artery on table that will need to be decided on.
Is the right hepatic duct formed? Follow the right anterior and posterior? Are they joining? I saw the septum of anterior and posterior. Yeah, that's the septum of anterior and posterior. But and are the obviously right and left are not joining. Now there is a secondary confluence in the left also, which is joining of the left duct after 2 and 3 have joined, and segment 4 duct. Is that confluence? That confluence is involved. What is the significance of that?
It is not segment 4 or 3 की तो जुड़ रही है, 2 separate हो गई है, देखिए फांसी तक ट्यूमर चल रहा है, तो भी पीछे से आ रही है वो डॉक्टर सेपरेट, ये बहुत एक्सटेंसिव ट्यूमर है, लेफ्ट में कितना एक्सटेंड कर गया है, देखिए segment 4 और 3
There seems to be significant crowding of the biliary tract in the left lobe.
Yes, sir. There is.
He already pointed that out, that there is crowding of ducts in the left. So what I was trying to say, that suppose right anterior and posterior sectoral ducts are involved, they are separate, which means that you will have to do a right hepatectomy. And if on the left side, segment 4 duct also is involved, earlier it used to be said that this is unresectable. But again, with the use of measures to induce atrophy and hypertrophy, if you can ensure an adequate functional liver remnant, you can do an extended right hepatectomy, which means that then you will be dividing the left duct beyond the point where the 4 is joining. Obviously, in all these cases, you will have to do a frozen section, and what is left is only segment 2 and 3. So that bilateral secondary confluence involvement is not a contraindication for resection, but it involves more major resection in the form of an extended right.
So the reason for the atrophy of left is the involvement of left.
Yeah, show the portal vein now.
So here we can see discontinuity of left portal vein. Right is formed with the division of the posterior vein, but in left there is involvement of left portal vein. There is no continuity of left portal vein.
So how do you describe involvement of vessels on CT?
Of the vessel. When the involvement is there.
This is encasement.
This is complete
Vessel
360.
Back to home, that is encased by the tumor. That's why it is not opacified.
It starts with proximity, then abutment. Abutment means less than 90% involvement. 90 to 180 degree involvement is suspicious. And if it is more than 180, if there is change in caliber, if there is change in shape, that is definite involvement. And last, of course, is complete occlusion or thrombus, presence of tumor thrombus. So here, in one part, you don't see the left portal vein at all. So probably it is a complete encasement, and that is the cause of atrophy. Arterial involvement usually does not give rise to atrophy. It is the portal venous involvement. Also, long-standing biliary obstruction can also cause atrophy, and that is the cause in benign biliary stricture. When you have recurrent cholangitis in a part of liver, that part can undergo atrophy.
So there seems to be a good right remnant. Why don't we do a extended left hepatectomy rather than a right hepatectomy?
It will depend on what is the ductal status of the right duct.
They are coming close. I think despite difficulty, 1 to 2 anastomosis can be done.
Yeah, but margins are likely to be positive. So you
Yes.
will have to accept an R1 kind of.
We can't exclude field change. But what has been shown is microinvasive carcinoma has the same prognosis as a negative margin.
I think MRCP, and now of course we have PTBD, so a good PTBD gram will tell us what is the ductal anatomy.
Yes, sir.
See on the CT scan, come back to the right bilateral anatomy. The right bilateral anatomy, yeah, go down, 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 down.
This.
Yes,
Yeah. Yes.
Even prior to separation, there is a tumor over.
Yeah.
Yeah. You see here,
Yeah.
this is the right anterior posterior, and come back, come up, come up, come up, come up, come up. This is a tumor.
Yeah.
Still there is a tumor. So it is unlikely that you will get a margin over.
Yes.
Unlikely on the right side you will get a margin.
I mean, theoretically, Rajesh, what you are saying is right, that the tumor is more on the left side and involving the left vessels, but even on the right side, it is very close to the junction of anterior and posterior.
Yes, sir.
Harshil,
It might be 2 different anastomosis. I think giving the patient a chance, we should have a trial resection.
Arshi Khan wants to know if we are suspecting carcinoma, should we go for PTBD? Is there... Arshi, you are right. It is not called skin metastasis. It is called needle track implantation. And that is why almost all Japanese centers and surgeons earlier they used to do, they were very fond of percutaneous transhepatic cholangioscopy, percutaneous transhepatic biliary drainage. But now most of them have changed or shifted from percutaneous to endoscopic. And they say that with experienced endoscopists, even in cases with biliary ductal confluence block or even with secondary confluence block, they are able to place stents into whichever system they want to drain. So most Japanese centers have now shifted from percutaneous to endoscopic. So if you have the expertise and experience, endoscopic is always preferred. But obviously, it is going to be very demanding.
पानी गर्म हो सकता है बर्तन बैठे ना बाकी में
I feel that it's very close to the junction of the anterior and posterior on the right side. So even if you do a left or extended left, the margin is likely to be positive. Because as Dr. Ajay was pointing out, on the right side, the length of the pedicle, both main pedicle and sectoral pedicles, is not very much to give you surgical liberty, which you have on the left side.
Yes. Right side पे वो तो left beds. Right 7 पे देखिए ये दिख रहा है ना वो मैट से बड़ा सा दिखता है बहुत ही तेज स्क्रॉल कर लिया नीचे दिखेगा ये रहा वो
There is a suspicion of
outer
hypodense metastasis in the right posterior sector.
segment का बड़ा सारा ये बेड्स ही है.
I think we are 7 minutes beyond 10, so we will close. Maybe we will continue with the management of this case in one of the other sessions. Thank you everyone. Thank you, Rajen.
Yes, sir. Thank you, sir.
नीचे टैग करके कोलेंजुलर एक्शन से तो मैंने एफएमसी कहा बेड्स ही है तो